This year in ESMO, we have presented a abstract on immunophenotypes of male breast cancer, and we used radiomics to predict the immunophenotypes in male breast cancer. So the first question arises is why radiomics when we have very good standard imaging like MRI, PET CT? Because as a clinicians and researchers, we are all always in search of better biomarker, and radiomics is such evolving translational imaging biomarker. Most of the times we look at the CT, MRI, and PET CT as the biomedical images and takes the radiologist opinion, but they have much more information than that. But we need tools to look deep enough into those pictures to get that information, and radiomics is such tool. So to define, radiomics is basically a practice to convert the normal conventional images into highly mineable data by extracting quantitative features from these images. Although this looks like a complicated procedure, there are sequential steps which I am going to discuss now. So the first question arises is, can we use these radiomics in the clinical practice? Definitely, yes. If not now, in the future. How? Because there is features when we correlate with the clinical, pathological, and genomic data. And after correlating, we can develop the machine learning algorithms, and we can use these algorithms to predict the outcomes of unseen data. That is the really interesting thing. We can predict the outcomes of unseen data, and we can use these algorithms to predict on the newly diagnosed patient cancer datasets, imaging datasets. So that is the real potential of radiomics. In the abstract we have presented in ESMO, we have used two datasets. One is male breast cancer dataset, and second is female breast cancer dataset. In the male breast cancer, we have used K67 less than 14 and greater than 14 as a high and low grade, and P53 mutation status because it's an important prognostic factor, although it is not routinely used. So we extracted the phenotypic features, quantitative features from the images, and from each image, nearly 850 radiomic features were extracted. And the features that are correlating with this positiveness of the P53 mutation and K67 greater than 14 or less than 14, and we have developed algorithms, and we use these algorithms to train the models, and then later on we used them for the validation of the unseen data sets. And to our surprise, we have achieved 75% accuracy to predict P53 mutation status and also this K67 grading. However, main limitation of our study is we have very few patients. We have used only 20 patients, and for a good training algorithm, we need at least 100 patients for a good algorithm. Similarly, in female breast cancer patients, we have trained the algorithms and able to predict with 80% accuracy on the first imaging of the patient whether it can be really hormonal positive or HER2 positive. The potential is if we can predict the BRCA in the same manner, so that in the resource constrained setting like in India, we can use these algorithms to predict who need to undergo genetic testing. And coming to the steps of radiomics, the most important step is equation of the images. We need homogeneous images, so image equation protocols. It is the difficult step because each institution, each mission has different image equation protocol. In our institution, because of the same protocol, we are able to get some data. However, we lost some of the patients who have undergone imaging outside.